Katie, Christian mentioned CSF involvement, which can be present in some patients as well. I know the practice is somewhat variable, but if somebody has a lesion which is biopsy-proven lymphoma, do you always evaluate CSF as well to document the CSF status, or do you basically follow the response of the primary lesion to therapy?
I think it's critical to get CSF on patients. It's part of the workup. You do want to evaluate that. It can be challenging in sampling. There can be sampling error associated with it, along with just needing to get enough CSF to evaluate appropriately. But it is customary for us to do that for our patients. If it is appropriate, if they do have CSF involvement, is then to follow it. The question is do you want to do something more aggressive? I would say personally in our elderly frail patients, I don't necessarily lean towards doing a Maya's unless it is really indicated.
For even consolidation down the road, like as a potential outlook. First, if you have involvement of the cerebrospinal fluid or not, it doesn't seem to make patients more vulnerable not to respond. It's not like leptomeningeal involvement in other cancers. Seems not to be a prognostic factor. But I think what you just heard, we need consolidation, but maybe we overtreat some people and we undertreat the other patients' population, and to find or define the right patient population is a problem. We don't have a minimal residual disease biomarker. And there was just this year, there was a publication in JCO by Mutta et al. They looked in circulating tumor DNA, and there seemed, and we also looked this, and we initially all thought that circulating tumor DNA in the CSF and mutations in the tumor are equally present, but it doesn't seem to be that way. It seems that patients that have circulating tumor DNA in the CSF have a higher risk or have a poor prognosis than if you don't identify them. And that might be a biomarker. And that might also be potentially a way to modify our consolidation regimens. Maybe we don't need to transplant everyone. I know that we transplant young patients, and with young, we define patients 70 and younger. And so maybe some of those 30, 40, 50-year-old patients, we don't need to do the transplant because they're not at risk of early recurrence. But I think it's an exciting time, and some of these questions will hopefully be answered. Problem, again, is that we do not have a lot of phase 3 studies to compare head-to-head because it's still a rare disease.
So bringing a very important point, because this definitely can maybe guide our therapy in the future, if validated in the future studies, particularly randomized studies, right, of this approach. Do the patients really need the consolidation? But you mentioned that mutations in the CSF are sometimes different than seen in the tumor. The actual mutational pattern, or just the load of the...
Load, not the mutational pattern. Usually, if you have circulating tumor DNA in the CSF, you have them also in the tumor. But yeah, it's more the scenario that there is nothing in the CSF. And again, that seemed to be a pattern that those patients do better.
Definitely, we can get cells from CSF. We've done this before with particular patients. I would say we're really lucky. We have 6 neurosurgeons that are ready to evaluate our patients and are aggressive and about doing safe surgeries on our patients, including stereotactic biopsies. So I think with everything what Christian said, it's very exciting that there could be a biomarker. And so I hope the technology continues to expand, that we can not get better tissue for these patients. Maybe we don't even need to do a biopsy to begin with. Maybe the technology is going in such a way that we can, just utilize the cerebrospinal fluid and cell-free DNA. And then next, if we do have something that's prognostic, being able to tailor therapies in patients with CNS malignancies is really an important trend. We've seen this with medulloblastoma. We're seeing it in patients with pediatric cancers, and then also younger patients with gliomas. So if this ends up translating that we can prognosticate better, for that rare population that may not need aggressive therapies. I think that's really important. So I'm glad that Christian brought that point up.